Hello, everyone.
Hello.
Hello.
Aloha.
Good afternoon.
Aloha.
Shirley? Only Shirley is over here. Our faces, our
Hello. Can't hear you guys.
Hi, I'm here. Can you hear me?
Yes.
Okay, great. We're just waiting for everyone to log in. As soon as we get everybody logged in, we'll get started.
Oh, okay. I thought you started already.
No, thank you.
Oh, thanks.
You want to go back to bed?
Aloha. Thank you everyone for joining us today. This is a CME activity jointly provided by the Queens Medical Center and UH-JABSM Department of Geriatric Medicine. Upon completion of today's echo, please complete the evaluation form. Enter the name and the credentials of everyone viewing the geriatric echo for CME attendance purposes. As a reminder, evaluations are required to receive CMEs. You can find evaluations by following the link in the chat or at any time on our website and email advertisement. We offer free continuing education for this series when you complete our evaluations. Certificates are sent out the Monday after our educational series. Your comments are very important to the planning committee and will be used to plan future programs. We want to remind everyone that this is an ECHO webinar, which means that this session serves as a forum for mutual teaching and learning from experts and from each of us on the front lines. As the ECHO motto goes, all teach, all learn. So we'll take all of you to create this community of learning. A little bit about our format. After a short lecture from our experts, we will share expertise from the rest of the team and then open the time up for care discussions. We invite you to share any geriatric cases. It may even be on a related topic, non-related topic about today's lecture. Our interdisciplinary team is here as well, and we are all willing to teach and share our collective wisdom with you. Rita Bell Fernandez, MD, Winette Gaylord, Maribel Tan, Juliana Caldwell, and Layla Ventar. We only ask that you keep HIPAA compliant. Please do not say names of anyone. So please just keep that in the back of your mind when we open up the discussion. We just finished a 4-month series on mobility. If you're interested in viewing any of those lectures, you can find them on our website. We cannot offer certificates of attendance for videos you have viewed. Unfortunately, you must participate in person, online, in the actual education live to receive a certificate. We are now on a 4-month series on medication. This month, we will be talking about managing insomnia. Join us next month for managing psychotropic medications. I'd like to introduce today's speaker, Karen Lubomir, MD. She is an assistant professor in the Department of Geriatric Medicine, John A. Burns School of Medicine, where she has also completed her geriatric medicine fellowship training. She currently serves as the clerkship director for the required medical student rotation in geriatric and palliative medicine, and is in clinical practice providing home-based primary care at the VA Pacific Island Healthcare System in Honolulu. Thank you and welcome to all, and aloha.
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 Aloha. Thank you so much for inviting me. Can everybody hear me okay? Yes?
Yes.
Yes.
Oh, good.
Yes.
Okay. Oh, I like the
Yes,
thumbs up.
good.
Thank you. It's so hard because I can't see any of you. All I can see are my slides, so I apologize. If anybody during any part of this has comments or if somebody can monitor the chat for me, I'm not that technologically capable of doing both. So today, it's kind of interesting. I didn't actually realize this next series was all about medications, because I think you're going to see this topic is actually not best suited for using medications, although I think many times insomnia is managed with medication. Okay, next slide, please. Okay, so what I'd like to accomplish, so for all of you, is at the end of this, my part of this discussion, as well as the cases that will be discussed afterwards, is I'd like you to be able to recognize risk factors for insomnia in older adult residents. I'd like you to, I don't know, I have control on here. I'm sorry, state 2 interventions for improving sleep in older adults. And lastly, I'd like you to apply and be able to monitor the effective strategies to improve sleep in older adult residents. Next slide.
Dr. Lubimer,
Yes, yes,
you want to try click on your screen, then you can have control.
I can.
Yeah, try
Where
click
do
on
I
your,
click?
just anywhere.
I'm not, I'm on my iPad.
Oh, okay, I'll do it. Hold
That's
on.
my problem.
Yeah, no problem.
Sorry, I'm not on a computer. I have my privileges revoked. So I always think it's good to start out with a case. I provide home-based primary care. I have veterans that are in medical foster homes and care homes. I've been in clinic with multiple residents, and this always seems to come up. So I think this gentleman may be representative of some of the individuals that I've met and that you might all be familiar with. So this is an 82-year-old male resident of your residential care home. His medical history includes diabetes, dementia, an enlarged prostate, and arthritis in his knees. He just moved to your residence from his daughter's home about 1 month ago. Next. He goes to bed around 7:30, but he just can't fall asleep. So he watches TV until 11 p.m. Then you notice he's getting up very frequently during the night. He's disturbing the other residents, actually, when he uses the bathroom. He seems to be sound asleep, and you go in there and try to get him up, ready for breakfast, and just start the next day. Next slide. He's also complaining a lot to you and says, you know, I need a nap for an hour or so to refresh, recharge. And this happens after breakfast and again after lunch. And he is sleeping an hour or more each time. And then he frequently refuses to go to any of the appointments set up or any activities because he's just, quote, too tired. Next slide. So what do we know about the sleep disturbance in older adults? Well, first, next slide. Next. Do you think he has a sleep problem?
No.
Why can't, no, okay. He doesn't have a sleep problem, okay? Why can't he fall asleep? These are some of the questions. Why can't he fall asleep? Why does he keep waking up?
Well, maybe he has another underlying condition.
Okay, so maybe something else is going on. Thank you. Why does he keep waking up at night?
Because of using
Go to the
bathroom.
bathroom a lot.
Oh, gotta go to the bathroom. Keeps waking him up, okay? And how come he's so sleepy the next day? In the morning, he can't get out of bed, and then he needs to nap all day in the day. How come? Any thoughts?
Maybe he's depressed.
He's depressed. Just doesn't feel like doing anything, okay? Well, I want to just review what normal sleep looks like before we go into a little bit more about him. All excellent thoughts. So there are actually stages of sleep. We know this. They've studied people's sleep habits by monitoring them in sleep labs. And there's 4, depending on where you read, but there's typically 4 stages. Stage 1, I have no cursor, oh dear, is the lightest stage. And that's when you're just drifting off to sleep. It lasts maybe 1 to 5 minutes. They say 1 to 7 minutes. Stage 2 is also a very light, but a little bit deeper sleep where the body begins to relax. And if you're going to wake somebody up, it's best to wake them up at this stage if you need something. Stage 3 is a much deeper sleep. This is where your brain and body start to do their work of recovery, whether it be repair, any injuries, and I'm talking down at the level of a cell. Really, but your body really starts to recover. If you wake up somebody from this deep stage, they're groggy, very, very groggy. And you can see that happens in about minutes 20 to 40 minutes long for this stage. And then lastly, the last stage is REM sleep. That also lasts about 20 to 40 minutes. And that's where people start dreaming. They're actually paralyzed. They wouldn't be able to necessarily move, but they have very, very vivid dreams. And this is if you woke this person up, they'd have a feeling of being at unrest upon awakening. So these 4 stages, the graph down below, a typical 8-hour cycle, you're going to go through all these stages. And if you can look, I have no cursor, I'm so sorry. The wake stage, then you drift off down into stage 1, that light stage, stage 2, deeper until 3, and then stage 4. Then you go back up. This is actually considers REM sleep the 5th stage, but and then you have these periods of REM sleep, then drop back down into a deeper sleep, come back up. But you're going to cycle throughout the night. You can see there's maybe 4 cycles in this 8-hour period. Next slide. older adults, some sleep facts. About 50% of all older people report some type of sleep problem. But insomnia is actually not a normal part of getting older. It's actually a disturbance in sleep. Older people do have more trouble falling asleep and staying asleep. Next. They spend less time in deep and REM sleep. And before you hit that button, if you look over here on the circles where you have infancy, maturity, and old age, you can see how the cycles are, how it's broken up. So infants, we know they spend a lot of time sleeping, as evidenced by the two, the blue, dark blue and the lighter bluish green or turquoise color, and less time awake. As we get to be adults, we spend more time awake. We also have non-REM sleep and then REM sleep. And then lastly, older people spend actually more time, about the same amount of time awake, excuse me. But when you look at their non-REM sleep, those stages, they actually have a little spike of orange, which is awake phases. So they may actually have very light or even awakened during the night. And then REM sleep is much smaller, occupies a much smaller amount of time. Next. So they spend actually more time in the lighter stages of sleep. They wake up more frequently, as shown in the little circle, right? And so it kind of interrupts their sleep cycle, and they may actually feel less rested. Last. Older adults sleep between 6 to 8 hours in a 24-hour period. It's not the 16 hours of infancy or even the 8 to 9 hours or 10 hours of youth, but it's actually a much shorter period, between 6 and 8 hours required. Okay. Next slide. So what are some of the risk factors for developing a sleep problem, such as insomnia? Well, first let's start at the top of this environment. If I asked you, what keeps you awake at night? Well, it's too noisy, the neighbor's dog is barking, the room is too cold, the room is too hot, there's too many lights on. Oh, never try to get any rest or sleep in the hospital, very loud, noisy, or any other maybe institution. Or even if you've moved somewhere new, if you go on vacation and you're in a new home or hotel, very difficult sometimes to sleep. Or if for an older person, if they've moved to a facility. Some of the behaviors that we see that place people at risk for insomnia, going to bed at all different times, not having a set bedtime is a risk. People who have caffeine later in the day, don't forget hidden caffeine. Even chocolate may have a small amount of caffeine that people can be sensitive to. People that drink alcohol near bedtime. If there's some emotional stressors, such as death of a friend or family member, that may be a risk factor for insomnia. Lifestyle change. So some big event like retirement can also be a risk factor for insomnia. And then frequent napping is a risk factor for developing insomnia. Medical factors are many. This is a short list, but right at the top of the list are medications. Every medication is a side effect. I'll stop there. And then other sleep problems, such as people have sleep apnea, or they have restless leg syndrome. Some people with PTSD have dreams in night, which may wake them or frighten them. Persons with dementia are at risk for insomnia, depression or anxiety, as somebody mentioned before. Diabetes is also a risk factor, or other heart diseases. These persons who've had stroke, or people who have chronic or acute pain are also at risk for insomnia. Next slide, please. So what is the caregiver's role in insomnia? Watch and write it down. Next. You are in a unique position to monitor everything that's going on. The first thing, if you were to go in or someone's going and complain to their physician or clinical provider, I'm having trouble sleeping, they want a sleep diary. And if you don't keep it, maybe they ask the bed partner to keep it, but for you all are in a unique position to watch and write down. So you're going to look at actual sleep patterns. Next. What's the level of activity for the individual during the day? What are the patterns of activity? Are they spending the entire day in bed? Are they getting outside? Are they engaged in any mental or social stimulation or physical stimulation? Next. Their behaviors. What do they do? How are they eating? Much are they drinking maybe before their dinner? Are they having caffeine? Do they seem depressed or anxious? And also then environment. Those are the things like temperature and the lighting in an unfamiliar bed or living space. Next slide. Oh, sorry, next. And as I said, write it down. Those are, whoops, go back. Those are the things that are going to give a clue on how are you going to manage this insomnia? How are we going to address this? And you're in a unique role where you have the front row seat into what's going on and just have to, for 24-hour period or several days, whatever, write it down, write out what's happening. Next slide. So I made this slide. I know it's very busy. You're looking for patterns. What is affecting the insomnia? We'll start at the top with exercise. Are they exercising? How much? When? And where you exercise, I don't mean going to the gym and lifting weights. So that will, if you do that late enough in the day, that could impact your ability to fall asleep. But are they even getting up out of their bed and walking the distance to the dining area? Is there any stimulation as far as physical exercise? And when does that occur? Too late in the day, too much activity can impair or affect how they can fall asleep. The green circle, what time do they wake up for the day? What does that normal look like? Have that written down. What time do they actually go to bed at night? And is there a lag time between that and the time they actually fall asleep? Our gentleman, went into bed at 7:30, but he didn't actually fall asleep until 11. That's like 3.5 hours he's been in there in his bedroom, not sleeping. What about sunlight or daylight exposure? It doesn't have to be outside, but even just having their curtains open. How much light are they exposed to? This is very important when we're sort of setting our rhythms. We have a hormone, which I think people are pretty familiar with, called melatonin. And that melatonin is very sensitive to light. So when it's bright, melatonin is not produced by the body. But as it gets darker and darker, the melatonin, the natural hormone in your body, that hormone rises and helps people feel sleepy. We'll talk about melatonin a little bit later. Other things to watch at night. What are their habits? What's their pre-bedtime habit or their evening habits? Are they watching television? Are they using a computer or a phone? We know from younger persons that how much time they spend on their phone with that blue light, and why do blue light glasses, which may or may not work, why do they sell so rapidly? It's because we're thinking that the effect of blue light depletes melatonin. Other things, eating and drinking. Are they eating a big, heavy meal right before dinner, or are they skipping dinner? So maybe in the middle of the night, they're actually waking up hungry. Are they drinking a lot of liquids right before they go to bed at night? Are they having caffeine? Some people are exquisitely sensitive to caffeine. They can't even have caffeine after noon, or they'll have trouble sleeping that night. Some people have no problem, but definitely understanding how caffeine is factoring in, you should notice that. And then hidden sources of caffeine, things like chocolates. Naps. How many, how long, and when are they occurring? Very important to know. And then how much time, the purple dot up there is how much time are they in bed actually not sleeping? They're lying in bed, reclining, resting, not sleeping. How much time? These are things that need to be noted. And lastly, the bright red circle, how many hours, if you added them all up, the mini naps, the micro naps, the long naps, and the time that they're sleeping in their bed, how much occurs in a 24-hour period? Very important. Thank you. Next slide. So other roles for the caregiver, looking at their medical problems. And this You'll know from experience, from asking questions, but some medical problems we know have associated sleep problems. I mentioned a couple. I said things like dementia previously. Next. But there are also things like diabetes for fluctuations or changes in blood sugar may come in, having an enlarged prostate gland, if they have any underlying infection, maybe they have dry skin and they're itching during the constipation because they're somewhat uncomfortable. Dementia, just because the way the brain is working, we see increased risk for insomnia. Parkinson's disease, they have disturbance in their sleep cycle and puts them at risk for insomnia. If people are having reflux or something like dysphagia, like swallowing problems, also can be a problem for insomnia, waking somebody up in that lighter sleep stage. If they have pressure sores, so they're uncomfortable. Other things would be things like arthritis. So where they go to bed and they're having pain, or they turn a certain way and have arthritis in their spine and it's sore, so the pain wakes them up. Next. Another thing to look at are individuals or his medical conditions, are they well controlled? Is his diabetes well controlled? Is he on medication for dry skin or constipation? How is that controlled? Or reflux medication? Next. Is he in pain? Pain is an overlooked issue for people trying to fall asleep or maintain sleep. One of our psychiatrists that I work with in geriatrics, when somebody's having problems to sleep at night, one of the first medications she likes to have the caregivers or family members administer would be acetaminophen, otherwise known as Tylenol. Make sure we've taken pain out of the equation. We want to make sure that's well treated so the individual is comfortable for the night. Next. Next. Oh, here we go. Another thing to do is look at the medication the individual is taking. There are every medication has a side effect. But think of things like, is he on a water pill and what time of day is he getting it? Oh, is he getting it too late in the day? Or do they need to be on twice a day water pill? So you have to figure out how to space that out. Are they taking something like a steroid or prednisone, which can be very activating? Some of our antidepressant medications actually are a little bit activating, and even some of our dementia medications, such as donepezil or Aricept, can be activating. Are they using albuterol for asthma or COPD? Because albuterol, the method of action, one thing it does is it actually causes the heart to race a little bit. Some people feel jittery or shaky. If you use that too close to bedtime, that may factor in when they can't fall asleep. Always ask, are there side effects to medication which might be causing his sleep problem? Next. So I always say, ask about the side effects of prescribing doctor, APRN, whoever's the clinical person. Next. Oh, and lastly, talk to a doctor, nurse about your observation. Ask questions. Next. Next. So how do we manage sleep problems? Non-pharmacologic, that means non-medication way, has proven to be the best. Next. And there's 4 methods here that we're going to talk about. Sleep hygiene, stimulus control, sleep restriction, cognitive therapy, and the last one is paradoxical intention, which I'm not going to cover today. If you note, next, the 3 with asterisks are performed under the supervision of a doctor or a therapist. Do non-pharmacologic treatment, or so non-medication treatment of insomnia, how well does it really work? Next. It's been found to improve in symptoms of insomnia in 70 to 80%, even higher in other studies I looked at for primary insomnia problems. And the effects last at least 6 months, even after you complete whatever treatment work that you've gone through. So next. So the first one in non-pharmacologic magic, and many of you have been practicing this already or have heard of this, it's called sleep hygiene. And what that's really about, what it helps with is falling asleep and staying asleep. It's really about educating the person or the caregiver about sort of the health and environmental practices that can be affecting their sleep. This is always done in combination with some other sleep techniques. So yep, go ahead, thanks. So sleep hygiene, I don't know how diet got on there, but let's just walk through sleep hygiene. So diet being one of them. Again, we just talked about high sugary, high fat, large meal before falling in bed. Or we know with some dementia persons, by the end of the day, their dinner is their worst meal. So they may actually be hungry at some point in the night, and that might be something waking them up. Next. Health factors, sorry. My animation went a little awry there, excuse me. Next. Other things that can impact, as I pointed out in your observations, would be looking at exercise, or I'm going to call that activity level. I'm not sure how many of our residents are actually like this woman performing her aerobics there, but people need a certain amount of exercise to move their body. Oh, but you say, oh, but they're bed bound. Well, getting out of bed, just that stimulation of that physical activity and range of motion exercises, that is exercise. Are they doing exercise? Or if they are actually able to get up and around, are they exercising too close to bedtime? The next is use of substances. And that's things like people do use recreational substances to fall asleep. And that includes alcohol. Why alcohol, some people say, oh, it makes people sleepy. Yes, it does. But the quality of sleep and their ability to stay asleep is impaired. It does not sustain or improve the quality of sleep. Pain, untreated pain, I talked about quite a bit. Trouble swallowing, those persons with dysphagia, or persons with Parkinson's or dementia or having had strokes. If they're having trouble swallowing their food or liquid during the day, at night they may be having trouble managing their saliva at night. So this may wake them up, so they're coughing or making choking sounds, which brings them out of their sleep. And then symptoms of other medical problems. So things like heart failure or sleep apnea, diabetes, if the blood sugar goes too low. Some factors with their medical problems may be waking them up. Environmental factors, I already talked about this. All I think about is being in that hotel room too close to the elevator and the noisy people coming on and off. Noise in older persons, because they're in the lighter stages and are more frequently awoken, noise is a big factor. Some people may use white noise, something like a fan or even air conditioning, to either mask background noise or provide background noise. And people use very low level of calming music to help us sleep. Again, lights, maybe low light, so that the room is not pitch black, but too much light can cause a problem. The temperature of the room, it's all personal preference. I also have to say that mattresses make a difference. Is it lumpy? Is it too hard? Is it, it's not their own mattress they're used to, may impair their ability to fall asleep or stay asleep. Maybe there's a mattress pad on there, something because the person's incontinent, and when they roll over, it makes a crinkling sound. It may wake them up. Or if it's useful to make sure that the mattress isn't ruined, if it becomes where the sweat kind of gets trapped there because it's a plastic type material, and the person wakes up because they're uncomfortable because they're sweating so much. Next. The second non-pharmacological management I want to talk about is stimulus control. This is what cues our body and our mind for sleep. Well, if I asked all of you, well, the sun went down, it gets dark. Oh, we're getting ready. Our melatonin levels are going up. But if you use stimulus control, this helps with that getting to sleep. Next. So go to bed when sleepy. Use the bed only for sleep. Establish bedtime routines. And okay, after dinner, we brush our teeth, we read a story, we get take our bath or get on our sleeping clothes, whatever those routines are. It gets cueing the mind and body, especially for persons that have dementia, because it's a signal and they enjoy routine. It's very comforting and safe for them to have these routines. So having that gets their body and their mind prepared for sleep. Also, there should be a regular morning rise time. Get up at the same time every day. No sleeping in like our gentleman till 8 o'clock. Yep. And lastly, avoid I have one more on this list. Avoid napping, or used to call them power naps. Really 20, maybe up to 30 minutes. I think if you look back at the sleep cycle in the second sleep stage, you can make people feel rested if they have a very short, I call them power naps, but these are never over 30 minutes long. But because otherwise what happens? You sleep 2-3 hours. They only need 6 or 8 hours of the day. We've already decreased the amount of time that they will sleep at night because they've already spent that time during the day sleeping. Next. Here's one that is used, one of the ones that we do with a therapist, and that's sleep restriction. This is something that helps with the middle of the night wakenings. And the goal is that anytime the person's in bed is spent sleeping. So let's, for an example, someone goes to bed at 11 o'clock and they get up at 8 in the morning. Well, that's like 9 hours, isn't it? But they're really actually only sleeping 6 of those 9 hours. So there's 3 hours they're just laying there. So what this restriction does is said, okay, we're only going to let that person be in bed at midnight and then get up at 6. And see, it's the same 6 hours, but it's quality. Anytime they're in bed, they were asleep. Then if they're sleeping through the night, which may only take about a week at this new schedule, the bedtime will be adjusted 15 to 30 minutes earlier. So they then go to bed at 11:45 or 11:30. Again, this is done with in conjunction with a therapist. The things that have to be done, the wake time has to be constant. No sleeping in on Sunday morning. And then it's the bedtime that's actually gradually adjusted. It does allow for some short afternoon naps in some of the techniques that the therapists use, but extremely effective. The last one I want to touch on is cognitive behavioral therapy. Again, with a therapist, it helps with those psychological problems that are interfering with sleep, the anxieties, depression, but it also identifies if there's any beliefs or attitude about sleep, and they try to replace those with thoughts and techniques on how to adapt. Also, it minimizes any anticipatory anxiety or arousal, because what happens sometimes is people are a little bit they say, I know I can't go to sleep. I'm so afraid tonight I'm not going to go to sleep. And that becomes a cycle. But this is something that helps with therapy. And then they can also teach relaxation techniques. So here's where we touch on medications. I just have a couple more slides. Medications are not recommended for long-term use for sleep. Wouldn't it be lovely if every resident went to bed at 7 p.m., slept the whole night, and woke up at 7? And wouldn't it be wonderful? Oh, they could just do that on their own, but maybe they need a pill to do that. No, actually, it's not recommended for long-term use. There are, as you know, with medications, every medication has a side effect. And because we're dealing with sleep, and you want somebody to induce sleep or have them get to sleep, it likely is affecting the nervous system, but many other parts of the body as well. So prescriptions are based on the underlying problem with sleep. That's where your diary comes in. That's where your observations come in, because you are the eyes on what's going on for that resident. The prescriber needs that information to make a proper diagnosis and identify the underlying problem. There are over-the-counter medications. I talked about with your available non-prescription. Melatonin is probably the one that's everybody knows about the most. Typically, again, looking at the most recent studies, they suggest starting at a very low dose. If you go into longs, hard to find. You don't find 0.5 milligrams of melatonin on the shelf. They start at 3, 10, 8, all kinds of doses. But for older persons, the recommended starting dose, because you don't know how they're going to respond, is about 0.5 up to 1 milligram, but starting very slowly. Other things that people use that are non-prescription, they might take an antihistamine, such as Benadryl. The side effect of Benadryl, oh, it's great for itching or allergies, but the side effect is drowsiness. In older persons, it also can be associated with urinary retention, so they can't shishi, and also can be associated with constipation, confusion, falls. This is an absolutely not indicated for use in older adults. Other sort of herbal preparations, I think the best one that I found was valerian root. Unfortunately, this has lots of side effects, including possible liver and gastrointestinal side effects. Not recommended at all. There are other things like chamomile, which I didn't find side effects, but people make a chamomile tea or something. And then I highlighted the 2 that have the most side effects. Next. So other considerations, what are the doctors or prescribers thinking? The goal of any medication would be they want to improve the onset of sleep, improve the person's ability to stay asleep. And so they're going to select and dose the medication according to the symptoms and how they're being controlled. The safest prescribing is the lowest effective dose. It's only for intermittent use, meaning maybe 2, maybe up to 4 times a week. And it's for very short-term use, not to exceed over 4 weeks of use. If they are taking relatively routinely, it's got to really be tapered or to reduce some of the side effects that people might have from abruptly stopping that medication. Okay, let's go back to our case. So here he is. No, melatonin can't cause constipation. Melatonin, no, it's Benadryl that causes the constipation. Rowena, I saw that. 82-year-old male resident. He's medical history. He's got diabetes, dementia, large prostate, and arthritis. He moved to your residence just 1 month ago from his daughter's home. Next. Goes to bed at 7. He can't fall asleep, so what does he do? Turns on the television until 11 o'clock. He gets up a lot during the night and uses the bathroom, and it's upsetting because your other residents, it may disrupt their sleep cycles. He seems to be sound asleep. He really doesn't want to get up at 8 o'clock when you try to wake him up. And lastly, it's also, he's unhappy. He's complaining. He always seems to want to nap. He's napping an hour or more after lunch, and again another hour or more after breakfast. He also frequently refuses to go to appointments because he's just too tired. So it's possibly impacting his his health. So what about our resident? What could be causing his sleep problem? I just put it in here. Well, he just moved in. Is he anxious, depressed? He's in a strange environment. He's only been there a month. He was living with his daughter. He's watching television. So we know that blue light decreases the formation and release of melatonin. Well, maybe he's watching some very stimulating TV program, something with a lot of action and excitement. So that might actually be very stimulating. And we know he sleeps in the day and at night. He's napping. So he's also spending a lot of time in bed. He doesn't necessarily associate his bed with sleep. And then, as I said, he's napping a lot. Whereas medical
Sorry to interrupt really quick. There was
Sure.
a question in the chat box about
okay, great.
melatonin, actually,
I just
a
said it.
side effect of melatonin. They're asking if melatonin can cause constipation.
I did not find that. What it's Benadryl can cause constipation.
So it's Benadryl that causes constipation, not the melatonin, correct?
Right, urine retention. And urine makes them not be able to make shishi, because confusion, falls, all those. Those are some of the side
There you
effects.
go, Rowena. I hope that answered your question. Thank you so much, Doc.
Oh, sure. Thank you. Thanks, Julia. So his medical problems, his diabetes. maybe his blood sugars are high, or maybe they're low. And either of these, maybe that's waking him up, especially if he has low blood sugar, can wake you up. He's got arthritis, our gentleman. He's having pain. Either it wakes him up if he's moving, or he just can't get comfortable at night. You know, he has a large prostate, and people mentioned when I asked what might be causing it, you know, just the large prostate, they have one of the side effects of having that is that they lie down and the body relaxes and allows the urine to, the shishi to come out, you know, kind of a relaxation of that region. Maybe he drinks a lot of water at dinner or something else at dinner time. So that would just that, as somebody mentioned before, that is waking him up to go to the bathroom. Okay. How are you going to fix him? This is your turn. What do you want to do for him? Should we go back to the case?
I think Jovelyn Garces has her hand raised.
Oh, I can't see. I'm sorry. Oh, here, let me go to that. Here we go.
Jovelyn,
Okay.
unmute yourself. If you want to type your question in the chat box, I can see it. But right now, oh, here's a question while we're waiting for Jovelyn.
Oh, sure.
Here's one. What is the side effects of prolonged use of melatonin?
You know what? It's one of the safer medications out there. So they may need to be on it long term. They're actually, melatonin has effects all over the body. So for right now, and it's been out there a long time, there's no known long-term effects of use. But people respond. But people respond differently to it. That's why starting with the lowest dose is the lowest and staying with the lowest effective dose.
Excellent, thank you. I think there was another response to the case study. Norma suggested cutting down on taking naps.
Yes, excellent. Yep.
And then there was another comment by Calvin Hara. Adult children of a senior in a care home may have been providing CBD to assist with sleep at home. In a care home, a physician's order is needed for CBD. Physicians do not write CBD orders. What do you suggest the care home caregiver PCG to communicate about CBD?
Oh,
Thank you. Great question.
That is a wonderful question, Calvin. Yes, CBD is not recommended in older adults again because it works on the brain, and especially older persons do not respond the same as younger people, especially in cases of dementia. We can see worsening confusion. So things like that could even increase risk for falls. It's not intended for older individuals. So I know if they are trying to get, sometimes somebody has a prescription or a medical, for medical marijuana and they share with others, that I would say would not be appropriate in your home. I think you have to have rules about that and decide what your what you're mandated by the state of Hawaii to allow. So if every medication has to have a physician's orders or APRN's orders, CBD could not be included upon that. I don't know if the other, like Dr. Hernandez has any comment on that.
Yeah, I do suggest that if the physician is not willing to write an order, please document it in your notes. Dr. Lubimir has suggested to monitor and watch and document. So please write it down in your charting. At least you cover yourself that family is giving this. So please monitor and watch. Thank you.
Thank you. Shorten TV at night. Yes. have a bedtime schedule, cut the napping at daytime. Yes, Melita, thank you. Excellent ideas. You know, turning, for all of us, I'll say, we should all include ourselves, we're all susceptible to that blue light. So really not having any screen time, as they would call it, like on television, computer, phones, within an hour, maybe some people are even more susceptible, within a couple hours of bedtime, and I'm going to call that sleep time, would be really important, yes. Other ideas?
Maybe a little bit more physical activity throughout the day to get them a little bit more tired at night.
Absolutely. If I put all of us in bed all day long, right, and you didn't move, how, and people who've been ill or whatever, or known or had to spend time for recovery or something, and been in bed, and it's time now to go to sleep, and you've been in bed all day not moving, we're not equating bed with sleep, so that's stimulus control, as well as we haven't moved our body, maybe aching, there's not that expenditure, you're not using energy, so maybe you don't get as tired. I think that's a really good idea. Avoid napping in the afternoon. Yes, about the fluids. Drink most of the fluids earlier in the day and late afternoon. Sometimes we say just sips. They have a nighttime medicine, a sip of water, to whatever it takes to wash that one medicine down, and then that's all. And then the caffeinated foods and beverages, yes, cut that out in the afternoon, absolutely. And as I said, some people say at noon, stop it, because some of us are exquisitely sensitive to the effects of caffeine. Exercise early in the day. Oh, have them see a urologist. Yes. Need to find out why he can manage that large prostate. And gabapentin, yes, has been listed and does help some people sleep. But again, because it works on the nervous system, it can make people feel drowsy or sleepy. But the prescription for that is, for the most part, either treating a seizure disorder or it's treating pain, nerve pain from something like diabetes or a stroke. So the doctor getting the history from you, and you made all your observations, and also then looking at the patient and their condition, may in fact use gabapentin in that situation. So that's an excellent idea. And then I like this, use a topical to remedy the arthritis pain. Absolutely. So I think that's underutilized. Just the massaging of the joint wherever he has knee pain. So even that massaging can stimulate a positive effect, but some kind of topical. We have a topical non-steroidal anti-inflammatory like diclofenac maybe, or Voltaren gel people have. We have lidocaine topical. We have menthol salicylate, like icy hot, all kinds of things. Instead of day napping, activity at day. I like that. Excellent ideas. Oh, here's a new one. Evaluating his nutritional intake. Yes. What is he eating? Is he balanced, right? Is he excellent? And then, and somebody's client has shingles. Very, very challenging. And somebody else has said salon pas. Yes. The capsaicin or the topical agent. Yes. Very helpful for pain. Oh, this is great. Okay. Just in summary, thank you, everybody. So you're going to keep a journal of the patterns. Observe. You have a new client with you. Oh, somebody else said relaxing sleep videos. Yes, some bedtime routine, music, videos, white noise, something that's relaxing. So you're going to keep this journal of patterns and your sleep patterns, activities, meals, liquids. We got a diffuser and chamomile essential oils. Yes, there's we use that also for behavior with dementia. Excellent. Aromatherapy. Very nice. Oh, replacing TV with calm music. Still getting great ideas. You're going to observe the environment. Are there any psychological issues? I think somebody said, is he depressed? Is he anxious? Warm bath, massage. Oh my goodness. Really sound wonderful. Bedtime rituals. Deep breathing. Oh my goodness. These are excellent ideas. Excellent. You're creating routines. So those for non-medication techniques, these are addressing all of those. This is the stimulus control. You're trying to set up something that said, tell the mind and the body it's time for bed. The other thing you're going to learn about the medical problems that they have, and all of you already have had experience with this. There are certain medical conditions that might cause or disrupt sleep. And you look at the medication list. And then lastly, I think there's one more. You're going to bring your journal, your observations when you go to have your discussion with the nurse case manager, with a physician, APRN, whoever the persons are involved in your care. I think that's all I have. More questions? Wow, this is a great answers, everybody. Thank you so much. Oh, get to know him. Oh, gain the rapport to ease his anxiety. Absolutely. The more familiar he becomes with his surroundings and things and comfortable with you, the better. That's what we do. Thank you. I think we can move on. Oh, more fruits and vegetables, avoid stomach. Ideas just keep coming. Oh, avoid stomach discomfort, regular bowel movements. You talked about constipation, maybe a trigger, uncomfortable. Excellent.
Thank you so much.
Oh, you're welcome.
Yeah. Now I just have like 2 minutes and I just need to cover just a couple items on COVID. So thank you very much. So just a couple of, some people have some questions about when do I take can I take that booster shot, right? So if you recently had COVID, the recommendation is that it's okay to wait 3 months because you are somewhat protected from reinfection. So that means like the date you have your first symptoms or the date of your first positive test, you can wait 3 months and then get your primary dose or your booster, right? But unless, of course, you have you or your loved one is very high risk for severe illness, then maybe you might want to bump it up a little bit. That's okay. But you are generally more protected after you get an infection in the immediate 3 months. Next slide. And also, people might be asking after May 11th, the emergency COVID mandates have been, done away with after May 11th. So what happens with the cost of vaccines, testing, and treatment? So the cost of vaccines, testing, and treatments will no longer be covered by the federal government. It's going to go back to the private sector. So health insurances must cover preventive care under the Affordable Care Act. However, those without health insurance, these interventions will become out of pocket. And so, but they will continue to be free until the federal supplies run out. So if you, this is the time between now and May to get your vaccines and to get your COVID test kits and things like that. So I just wanted to give you a heads up so you all be prepared. Next slide. And that's that for the quick COVID update.
Next slide, John. Thanks.
Next slide, John, please.
All right, everyone.
Go ahead, Michaela.
Okay, it's evaluation time now. So I just placed a link inside the chat box. For those of you who are just joining us this month or who don't know our system, we require an evaluation from everybody that wants their certificate of attendance or a continuing education certificate. So if you're viewing with more than one person in your home, you complete your evaluation and then have them completed as well. Maryville is asking if free test kits are going to be available for us. Anyway, so everybody, please complete an evaluation. Afterwards, you're going to get an email asking you to fill out medication information, like that's on the slide. We collect these periodically because we are grant funded, and our grant funders want to know about certain evaluation metrics. So we will collect this now. If you collected it last month, you don't have to do it again. If you didn't do it last month, please do it. And then we'll collect it again at the end of our series, and we'll do a little report to you. Go ahead, John, next slide. We do send out these evaluations with an automated system. So if you want one, you do have to complete one, right? We collect them over the next few days, and then John will send them out on Monday. If you are having problems getting them, it might be because you entered in an email address that is invalid. You can reach out to John, there's his email address, or you can reach out to me, and here's mine, and we can help you.
Yeah, I just wanted to get back to that question about the free test kits for the COVID. I think that it's not going to be paid for by the federal government anymore. However, it's going to be up to the different insurance companies whether or not. So if your client has insurance, then it possibly may be covered. So, but you'll have to check with the insurance company. I don't know if Juliana or Layla have any comments on that.
No information yet, doctor, but
Okay.
I'll definitely share once I hear back.
Yeah, same here.
Okay.
Well, thank you, everyone. Dr. Lubimir, that was a fantastic presentation. I learned so much. Starting dose of melatonin is 0.5. Please don't go buy all these gummies and things over the counter. They are at much higher dose. You taught us so much today, and care home operators and foster home operators, remember to watch and monitor. Like Dr. Lubimir said, please write these down in your chart. Please put it in your progress note. You were a wealth of wisdom, and we learned so much from your VA case of your patient in the care home. So thank you, everyone. And thank you for joining us in this ECHO session. And we will be together next month in March. So keep coming back. We are doing this monthly. And I thank you for your time. Thank you for your service. What you do is a very hard work. And our state of Hawaii, we wouldn't have enough nursing homes. We couldn't manage without you. So thank you so much for offering your home and your hearts to the residents of our community. Mahalo, and see you next month.
Thank you.
Thank you.
Thank you, Doc.
Thank you so much. Have a good day.